So one of the unmet needs going forward in the future is how to overcome osimertinib resistance. As far as I know, there is no fourth generation EGFR TKI in development. Most of the newer EGFR TKIs are third generation EGFR TKIs, so they're very similar to osimertinib. As far as dacomitinib is concerned, it is generally considered to be a second generation EGFR TKI, very similar to in class as the afatinib. So there is now published data on Archer 1050 that shows that dacomitinib has improved not just progression-free survival, but overall survival over first generation EGFR TKI. However, the study, the Archer 1050, excluded patients with brain metastases, and also there is about up to 60% dose reduction among all the patients who were taking dacomitinib at the recommended dose of 45 milligrams once a day. So in this World Lung Conference, Tony Mock is going to present the dose reduction at 30 milligrams once a day. And it seems like that the 30 milligrams, if you dose reduce to 30 milligrams, the efficacy is preserved. It may actually be slightly better numerically in terms of the progression-free survival and the overall survival compared to starting 45 milligrams. But this is of course biased because this trial was not comparing 45 milligrams versus 30 milligrams. It was just a dose reduction. So patients who are able to benefit from dacomitinib and dose reduced to 30 milligrams, so that it's a matter of the benefit and they can continue at 30 milligrams. But the lesson is that we learned that as long as you can dose reduce, you don't have to worry about dose reduction. If you can dose reduce to 30 milligrams, even to 15 milligrams, as long as the patient is getting benefit, you don't have to worry about dose reduction losing the efficacy. It's not a trial to compare 30 to 45 milligrams, but it's a benefit that if you start with 45, you dose reduce to 30, and patient is benefiting, but they need further dose reduction, it's okay to dose reduce because they will, as long as you put the patients on continue the dacomitinib. However, dacomitinib is still as a second generation EGFR TKI. It's not osimertinib. So I have a feeling that in the future, when dacomitinib is approved as a frontline treatment, it may actually be used as a second line post osimertinib failure. We have heard from the community that afatinib is being used post osimertinib. I think dacomitinib will be used post osimertinib. As far as dacomitinib as a frontline treatment, I think this is going to be it will be challenging because of the side effects profile. And now osimertinib is well established in the United States, the frontline treatment that dacomitinib is probably reserved as a second line option, although this is not approved to be that treatment paradigm.